Good afternoon, everyone. My name is Meena Dayak, and I am the Executive Vice President of Market Intelligence at Open Minds. You are just hearing my voice today, and on your screen, you see our stellar panel of speakers for today's web briefing. This web briefing on blended virtual and on-site services for continuity of care is brought to you as part of the Open Minds Executive Blueprint for Crisis Management, Building Organizational Sustainability and Success in a Disrupted Market. We launched this program towards the end of March, early April, to help provider organizations think about how to navigate through the COVID-19 crisis. And I would say, even though the crisis is technically not over by any means, we for a while have been helping our subscribers and our members navigate and start thinking about what recovery from the crisis looks like. You know, what is the new normal? What is life going to be like when we get back to whatever it is that we get back to? How are things going to be different? So we're looking at everything from virtual care to revenue opportunities to business development with a lens of long-term sustainability. And I am just really excited to have a great panel of speakers here today to talk to you about how virtual care has been working for them and how they have very creatively blended both virtual and on-site services to ensure the best service delivery for the consumers they care for. And we have both provider organizations as well as payer representatives on the panel. But first, I would like to introduce you to my colleague and Open Minds Senior Associate Deb Adler, who has put today's briefing together and brought all of our wonderful speakers together. Deb brings more than 20 years of experience in executive healthcare roles, serving in a variety of capacities, including network executive, quality management executive, and chief operating officer to the Open Minds team. Her consultant work with Open Minds spans a broad range of customers, provider organizations, payers, government programs, and she also is the expert on many topics, including collaborative care models, medical and behavioral health integration, provider network functions, contracting, network designs, recruitment, telehealth network implementation, and strategic planning. So an impressive range of credentials indeed. And she has a special interest in helping technology-enabled providers in go-to-market strategize and streamline network functions. So Deb, we want to thank you for pulling this panel together today, and we look forward to what you have to offer us. Just a couple of housekeeping reminders before I pass it off to you. We, all of you who are attending today's web briefing are in listen-only mode, but that doesn't mean you can't connect with us. You'll see a question box on the right of your screen. So at any point during the briefing, if you have questions for any of our speakers today, just type your question into the chat box and send it to us. We will address them either as the speakers are presenting, or we will save them for the end. Once we get through all of the presentations, we will definitely be here as long as it takes to answer every one of your questions. And I want to thank all of our speakers today for taking the time to share their experiences with us. We definitely look forward to your pearls of wisdom here. And with that, I will hand it over to you, Deb Adler.
Thank you so much, Meena. Welcome everyone to today's webinar. I'm going to start with introductions and some clarifications. I am not showing on the screen. My webcam is not cooperating today, but the show must go on. You'll just be hearing my voice as I moderate and facilitate this webinar. I'm going to start with Deb Nussbaum because she's on the left side of the screen and it says she's Deb Adler, but she's Deb Nussbaum. I have not let my hair grow longer, but I think Deb looks great today. And she's the Senior Director of Behavioral Health Product at Optum Health. She has led a number of initiatives at Optum Health, including the Substance Use Disorder Initiative since 2012. She's played a key role in the expansion of Optum's medication-assisted treatment network and overseeing their 24/7 SUD helpline, which is, I think, a unique thing in the industry as well. Deb has a clinical background. She's a licensed social worker, and also has a PhD in organizational psychology. So I welcome Deb Nussbaum to our panel. I'll also speak to the other payer participant that we have today. Erin Boyd is the Solutions and Program Director at Cigna. She has been leading the behavioral health network strategy for Cigna. And in that role, she's responsible for ensuring Cigna customers have affordable, quality choices when receiving behavioral health and substance use care. Not only does she oversee the network program and solutions, but she's been very focused on innovation, cost savings, and improved outcomes through her tenure at Cigna for the past 4 years. She has 20 years of experience in the medical healthcare field, including communications, marketing, public relations, and strategic planning. So I welcome Erin as well as a colleague that is going to also give us some great insight into what the payers' plans are go forward from a telehealth standpoint. We have two organizations represented as providers today. Lanty Jorenby is the Chief Medical Officer at Lakeview Health. She went to Vanderbilt University studying neuroscience, and then went to medical school where her residency was at the University of Florida. She's been the medical director at McLean Hospital through her career, and I think folks are very familiar with McLean. She also has served as faculty at the Harvard Medical School in the Department of Psychiatry, and she is one of less than 200 physicians in the United States who is duly board certified in addiction medicine and psychiatry and neurology. So welcome, Lanty. We have two representatives from Hazelden Betty Ford today. Since one focus of our topic today is really the research. What is the research telling us about telehealth? Particularly what are we learning from this COVID experience that will carry us forward into better understanding effective treatment delivered through this modality. So Dr. Quinn No is the Executive Director of the Butler Center for Research at Hazelden Betty Ford Foundation. She has a joint doctoral degree in clinical psychology and women and gender studies from the University of Michigan. She also has postdoctoral training in interdisciplinary substance abuse research, a program that was funded by the NIH as well. Today at Hazelden Betty Ford, she oversees the current research collaborations and establishes new research collaborations aimed at improving treatment and outcomes for the individuals and families that Hazelden Betty Ford works with to support addiction needs. So again, welcome Dr. No and her experience in research to this panel. And then last but not least, Pablo McCabe is the National and Strategic Accounts Director at Hazelden Betty Ford. He's a licensed social worker as well, with an extensive background in presenting educational and motivational seminars and webinars. He's managed wellness and training within internal and external EAP programs at Fortune 500 companies. And I think many people are aware of his tenure at Hazelden Betty Ford and the support he has helped that organization in payer relations as well as partnerships. So welcome Pablo as well. So without further ado, we're going to get into the content of the webinar, starting with the program objectives. So Stephanie, if you could maybe move to that slide in the agenda. We're going to talk a little bit about virtually delivered care in both what I would call intermediate levels of care, intensive outpatient and partial hospitalization programs, and really talk about how effective are those services when delivered virtually, as well as hybrid models where the delivery model might include both some face-to-face treatment as well as virtually delivered care, again, through a HIPAA secure platform. How does that, how our staff help to make that transition as well as the consumers? And then last but not least, how do we measure the effectiveness of these programs? What are the right measures that payers are looking at to measure the value and effectiveness of treatment delivered through these new models. So Stephanie, if you could go to the next slide. You know, when I think about virtual services and a hybrid approach, I will say with full disclosure that I'm a big fan of what you might call the hybrid model. And that's really the ability to meet the consumer where they are and offering them services that could be at their convenience through secure virtual means, as well as the ability to offer face-to-face as needed based on the consumer or member's preference. So I think we're entering into a new phase here soon where, you know, I don't know if we want to call it back to normal, but there are states that are beginning to reopen. When I look at the payer changes, and we'll talk about this a little bit towards the end of the session in the Q&A section, we are starting to see many provider organizations have to evaluate, you know, will they continue to deliver services virtually? Will they go back to face-to-face? And I'm hearing many providers are considering, you know, a little of both, right? A hybrid of continuing to address individuals who want that capability and the convenience and flexibility, and then providers too that are finding a lot of value in offering that flexibility to their workforce. A great example in terms of improvements that I think many providers have seen during this period when virtual has been really the practically, but not completely, one of the only means to deliver care in some situations, is no-show rates are going down, engagement is up, and you'll hear from our panelists what they've experienced during this period of time, whether they've been delivering purely virtual care or a combination of both, and how that's affected their key performance measures. So again, providers are really seeing it as a great flexible tool, and it also can make them reconsider what type of geographic footprint do they need. If you're expanding into new markets and delivering care both virtually and through face-to-face means in that hybrid model, you may not need the same square footage that you had before. So it's really, I think, developing into an opportunity to really look at the world differently and reevaluate, you know, how will the provider landscape look and how will it best meet the consumer needs going forward. If you go to the next slide, oh, this is the right slide. When I think about the measures that we would need to look at to evaluate, is virtual care working? Does hybrid care work? Does face-to-face care work? I think a lot of the performance measures, in my view, don't change a lot. I mean, we're still in the substance use space going to be highly interested in readmission rate and the mental health space as well. Typically looking at things like 30, 90-day and 180-day readmission. I think the world continues to be focused on NCQA's prominent measure, which is ambulatory follow-up within 7 days. Consumer reported outcomes, you know, hearing directly from the consumer's voice if they feel that there's improvement is important. Engagement rates, you know, are people participating in services over a longer period of time, which when you think of many of our panelists today, since they represent substance use organizations, they represent working with a population that has chronic conditions and where, you know, engagement and treatment is really critical and key because you're on a recovery path and journey that doesn't really end in one episode of treatment. Another performance measure is looking at migration to lower levels of care, or the reverse, migrations to higher levels of care, generally the goal being helping people function in the least restrictive level of care. Satisfaction rates, that could also mean loyalty rates through things like the Net Promoter Score. Average length of stay, ideally risk adjusted based on acuity. Episode costs, I know the payers, pay keen attention to this, as does Medicare, looking at episode cost to evaluate effectiveness and value, and then overall medical cost as well, the total cost of care. So those are performance measures that I know were important pre-COVID, before virtual really took off with a vengeance. And I would believe that these are going to be some of the same measures that will be key going forward as well. But we'll hear from our panelists on their opinions as well. So with that, I'm going to turn it over to Lanty, who's going to talk a little bit about the Lakeview experience and their services around IOP and partial hospitalization and what they have been doing in this area. So Lanty?
Thank you so much, Deb. And I just want to say thank you for allowing me to be part of this. I'm excited and really grateful to be able to share Lakeview's experience post-COVID and actually during the pandemic, what we've been able to do. So just a little bit about us. This slide just kind of highlights what we were like pre-COVID. And I think that the features that you see on this really gave us a leg up as far as our response to the pandemic, because one of the key features for Lakeview is that we take co-occurring disorders and complex medical disorders along with a substance abuse disorder. So we already were primed or kind of well placed or positioned to be able to handle and triage medical issues. We see a lot of people that come in with flu and respiratory illnesses already, and so we were able to pivot a little bit and incorporate the new knowledge that we were getting on COVID and make that part of our admission process. But just to highlight some of the things about us, so we are located in the North Georgia, South Florida area. We have a catchment that extends probably from that South Florida area up until the South Carolina section, but we take people from all over. We have about an 80% co-occurring disorder rate, meaning that we'll see people that have both PTSD, depression, anxiety, even eating disorders. And in addition to that, we also see a lot of those medically complex patients, whether they're getting treatment for cancer, hepatitis C, liver disease. We have a number of national partners, as you can see in the NFL Trust, Mayo Clinic, Cleveland Clinic, were big partners for us, and I think also part of our success with our COVID response. And then, as you were mentioning earlier, we have a measurement-driven system, so we do a lot of measurements on admission. We gather data on MoCA, GAD-7, PHQ-9, as you can see, and our scores on admission and post-discharge are, or at least at discharge, are pretty good. You can see that there is a fair significant drop with PHQ-9, for instance. That 7-day ambulatory follow-up rate is around 74%. And so this is all pre-COVID. If you look at these data, our relapse rates were at about 12.5%. So when we took a look at making that transition, and if you go to that next slide, that will highlight kind of what we were looking at when we kind of confronted COVID in the very beginning of March. We had three main goals. We sat down as a team, a leadership team, and we decided, number one, we definitely wanted to prevent exposure and spread of COVID to our facility, to our patients, knowing that a number of the morbidities and mortalities out of COVID were people that had co-occurring disorders, medical complexities. We knew that our population was at particular risk, and so it was very important for us to stay open and continue to be a place where people can seek treatment for their addiction, plus their medical and their mental health issues, because these are the patients that were going to suffer the most if they were to contract COVID. And then we really wanted to make certain we continued or maintain our servant leadership culture for our employee base. That is how we're built as an organization. So we put together some policies and protocols to support our staff during this very stressful time. And as I mentioned, our resources really pre-COVID served us well during this pandemic and continue to do well for us. So we're a 24/7 facility. We have nursing on site 24/7. And we're lucky and fortunate to have excellent board certified internists, psychiatrists, myself, and 2 other mental health providers that we could use these docs, these providers, to triage, assess, and we incorporated our COVID protocols into that. And another piece of this, which really I felt gave us that unique approach, was that we were able to use some longstanding partnerships. Mayo is local here in Jacksonville, Florida, and we also had long partnerships with local labs, and we were able to start doing coronavirus testing immediately. So when Florida actually set up our stay-at-home order, which was a week after we put our protocols into place, we were already testing appropriately per CDC guidelines and getting results back in a fairly timely manner. And so I think our long-standing partnerships really spoke to that, really gave us that advantage. So if you flip to slide 9, so some of these are not entirely what we have here on this slide is not exhaustive of what we've done. There's so much that we have done. I'm working on actually a white paper on it, but as you can see, I broke this down into facilities, employees, and patients. So if we look at the facilities piece of it, and I drew all of this from our CDC guidelines that were unfortunately constantly changing throughout this period, but we drew from that to improve our sanitation. We were improving just availability of hand sanitizers, signage, reminders of social distancing, and this was an important piece for our facilities. But we also addressed our employees immediately. So within that first week of a stay-at-home order here in Florida, we were screening all of our staff that came on site. We were doing temp checks, and we would be able to test. So the first test that we did actually was an employee. It was not a patient. And I had always talked with the leadership team about my concern that the employee base would be the source of an infection if it were to enter our facility. And so we were ready to respond to that risk. And so that was the first person that we tested was an employee. And we continue to test employees if they present with illnesses, symptoms. We've asked them to self-quarantine. So we put all of these protocols into place. And I think it has been very beneficial for us. Looking at, for instance, the WHO, World Health Organization, that came out, I believe, within the last week and saying that asymptomatic carriers are not as much of a risk of spread as we initially thought, although they walked that back a little bit. The screening piece was really key for us, making certain that we were asking all of the questions that the CDC continually updated, whether it be cough, fever, shortness of breath, adding in this loss of smell, and continuing to modify those questions for our employees that came on site. Another thing that I feel really worked, and this speaks to this ability to do things virtually, is that we put all of our non-patient care staff remote immediately. So within that first week of stay at home, all of our staff were set up at home with our IT department supporting them, and we were very fortunate to be able to pivot that quickly. And then if we take a look at the next slide, this just kind of sets up what we did for our patients. So initially, we were able to test very, very quickly within that first week of the Florida stay at home. We also tested based on CDC guidelines. So we weren't testing every patient that was admitted. We were doing screenings on everyone, but we were testing as appropriate per CDC. And then we were doing what we could to treat patients by telehealth. So a number of patients did present to us for admission that were symptomatic. They had either been exposed, they had been traveling, or they actually had fever, cough, or other symptoms. And so what we did was we actually swabbed them on admission, but did not bring them into the facility. We had them quarantine at home until we had the results back. And during that time, we were able to support them through telehealth services that we had through the facility. So checking in daily with them, not just checking in on their COVID symptoms, but checking in on how they were doing with their substance use or mental health issues. And then our nursing assessments were also pivotal here too, because every day that our patients are seen by a provider, we also have them seen by a nurse. And these are patients already admitted to us. We were doing the COVID questionnaire again, doing temperatures, even on patients that were in lower levels of care that don't necessarily need vitals every day. We were doing those temp screens. And then another piece that I really was excited about that worked out so well was our family workshops went virtual. We initially, pre-COVID, had a very good family workshop set up on a semi-monthly basis about every 3 weeks. And these workshops, because they drew families from all over the country, we had to turn them into virtual sessions. And really, this turned out to be so successful that we are going to continue that post-pandemic, because so many families have reached out and said they really enjoyed it. They felt it was very beneficial, but also very convenient and affordable. Thinking about travel expenses, thinking about difficulties taking time off of work, it really turned into a real boon for our patient families. And then going to the next slide here. So I think the real kind of key takeaway here was that with our setup here in Jacksonville, our Lakeview setup, we actually have 3 facilities. So 3 sites that are separate from each other. They're within a quarter of a mile, but they are separate facilities. And so we were able to set up one of those facilities as an admission quarantine facility. So all patients were transitioned through that one facility to prevent spread to the others. And we were able to test appropriately, screen appropriately for all those admissions. And then once they had been observed for about 3 to 4 days, they were able to transition to the other facility that they may have been designated for, because of the ability that we had with those 3 separate locations. And it was also a good way to manage if we had an infection that developed in one of our facilities. We actually did have a kind of what we call a fire drill. We had a suspected patient that had been in the facility for about a week but had developed symptoms, and so we actually had to close down one of our facilities for a period of time until we knew through testing that they were not infected. But that ability to close one down and just pivot admissions to the other 2 was really key for us, because it was able, again, to contain the spread. And given what we also know about COVID-19, the required quarantine period for our staff, we were very fortunate to be able to use HR and compliance department here to give us what we needed for staff and for patients, whether it be FMLA, whether it be working with leave issues, childcare issues, all of those things that go hand in hand with this kind of infection. And then just moving on to slide 10. As I mentioned earlier, and I think we're all aware of this, because the CDC seems to come out pretty much weekly now with updates and adjustments. The WHO is also continually updating policies. So that kind of environment around the pandemic really put us into a position where we were doing continuous quality improvement. And the ability for our leadership team to pivot the way we did, I think, really was remarkable, because initially, if you recall, CDC guidelines were just to screen every patient, but only test symptomatic patients. I think part of that was built on the understanding that we didn't have testing as easily available. We also weren't required to have masks available for everybody. It was only for those who were symptomatic as well. And once we noticed that there was risks for asymptomatic carriers, again, there's some debate still going on that point, but we were able to implement 2 levels of testing. So point of care, which looks for antibodies, and then a COVID swab. And we decided partway through, I believe it was early April, we decided we needed to do that on everybody. Because we had the ability, the available testing, we felt that was a necessary piece to implement, because we wanted to, again, protect our staff, protect our patients, those patients that are particularly vulnerable, the patients that are seeking treatment for us. So currently, this is what our process looks like. And then again, that 3-building campus really allowed for us to pivot from one facility to another based on need for quarantine, spread, kind of stopping of that spread or prevention of spread. And so thinking about how we kind of run our admissions, a lot of what we do now has pivoted to virtual. It has become very important. Again, as I mentioned, highlighting that family workshop, that has been a tremendous success. We're going to continue that post-COVID, whenever that might be, whether it be after a vaccine, whether it be at end of year or next year. It just has been so successful. But we also started IOP and PHP services by telehealth as well within the first month. And we got assistance setting that up because of, again, our compliance department. They were able to help us walk through a fairly complex telehealth and state regulation system, given that most of the telehealth regulations had been relaxed, but each state is so unique and each state has so many unique requirements or restrictions. But we were able to set up IOP and PHP services to various patients that were either had been discharged and needed to continue their lower levels of care, or who also were in our Texas facility. So though we are mainly located in Jacksonville, Florida, we actually have an IOP PHP facility in the Houston area, and that is completely virtual right now. As some of you may be aware, the Houston area is actually one of these new hotspots that had a spike in cases over the last week and a half. So we are completely virtual, partly due to that and partly due to the fact that we know patients really like this new way of doing mental health and substance use. They really like the adaptability, the affordability, the convenience. I actually saw a majority of the patients that we were admitting back in April myself because of some of these relaxed telehealth laws, and these people would be on their couch or they would be, talking to me from their backyard, and it was really a very convenient and affordable way for them to get treatment, to stay in treatment. They appreciated the fact that we were available to get help, because a lot of people, as we know, there's a lot of people suffering now from the lockdown as far as mental health issues and substance use issues. And then if we just go to the next slide, this slide just kind of outlines what we got out of our Texas facility. So the Woodlands, Houston area, our director and the staff really found that the census and the attendance spiked, which we were somewhat initially surprised by. But as we see this pandemic evolve into a mental health pandemic of sorts as well, it is understandable. And Mark Baumgartner, who is our director out there, he actually has seen a much longer program participation. So people are actually staying in treatment longer. There's fewer of these kind of atypical or AMA type discharges out there, whether it be from PHP or IOP. So we're seeing a really good positive result. Again, that convenience and affordability is a real pro. Now, some of the cons that we are working through right now are lab collection. As you are aware, our patients are co-occurring or dual diagnosis, so we are collecting labs for them to check for substances, and that has been challenging, especially virtually. So patients would be going to the local lab facility to do their lab collection, but with some of the facilities not open or available, that has been a bit of a challenge. We've looked into doing home testing, but again, there's a lot of things that went into that decision. It's been very difficult. Still working through that. And then one of the observations was that therapists, though they're very attentive in person, had to really put their powers of concentration into high gear when they're seeing people virtually, because there's a little bit less of that nonverbal that you can pick up. The picture might be a little murky, the connection might not be as clear as it could be because maybe someone's internet wasn't working as well. So these are some of the things that we've seen on the negative side. But overall, the pros have been excellent. And I think the cons really are things that we can work through. They're not deal breakers by any means. And then if we just hit on some of the performance measures. So as you recall, we do measurements on all of our admissions. So looking at our PHQ-9 data, for instance, we saw continuous reductions at discharge from admission on our PHQ-9 and on our GAD-7. Now, what you could take away from this too is that those numbers, for instance, the PHQ-9 during the pandemic, these are data from end of January through April, they're higher numbers for PHQ-9 and GAD-7 than we normally see. And again, I think that reflects that people are really struggling with mental health issues now through this pandemic. But the numbers still drop significantly through the treatment piece. So we are able to see those, track those, adjust our clinical programming to address specific things with COVID and with the mental health that comes out of that. And then our readmit rate, which had been around a good industry average, actually was quite low during this 3-month period. It was 2.3%, which I found remarkable. And then the ability to maintain and engage post-discharge. We have a very robust alumni and aftercare program. That actually, we saw very good numbers there. People are keeping their 7-day follow-ups. Because again, a lot of their docs are virtual, their psychiatrists are virtual, and so that was an excellent thing to see as well. So these are really good numbers for us, and we continually want to strive to improve them. And then if we take a look, I think there's one more slide. Nope, I'm sorry, there isn't. But I think that overall, we have seen a really big benefit from the virtual piece and from what we've been able to put together with our protocols.
Well, thank you, Lanty. We're going to turn this over to Hazelden Betty Ford and Dr. No and Pablo. Oh,
Sorry, taking myself off mute there. Thank you. So thank you for that, Lanty, and it's great to see another organization that has been so thoughtful about the processes and care for patients that I've seen at Hazelden Betty Ford. I've only been with Hazelden Betty Ford since January, so I'm actually relatively new to the team, and so I have to say that I've been really impressed with our leadership through this pandemic and everything. So I'm glad to see another organization that has been so full of care in their patient treatment as well. So I'm here to offer a little bit of a different perspective. Lanty gave a great overview of how a really nice response to a public health crisis can really help support patients who are dealing with addiction. And my perspective is really around the research. So I'm coming from academia, so I'm very research minded, and so you'll see that come out in this presentation, and the types of questions that I'm grappling with here at Hazelden Betty Ford, and that I've been brought on to really address. So really we're thinking right now about outcomes and evaluations and assessments of our programs. Why evaluate and assess using rigorous research methods? I think that as healthcare organizations, we really, we get into this because we care about our patients. We want to do good work. And so making sure that what we're doing is supported by the science and supported by the data is really important in terms of moving forward, and particularly when we are confronted with these unforeseen crises, and I'm sorry to say I don't think it will be the last public health crisis that we see, but hopefully we will learn from this process and know how to do the research that we need to support moving through this and helping our patients through this. We are looking at questions in terms of why do some patients do better than others on virtual? The assumption has really been that if you can do it in person, you can do it virtually, and it'll be the same for patients, that if they'll respond in person, they'll respond virtually. And we just really don't have the research or the data to back that up. And so those are some of the questions that we're looking at. In addition, we're looking at counselor and clinical staff and the factors that they may have and contribute to the success of patients who are doing virtual versus in-person care. So I'll talk a little bit too about the patients that we're following, whom we're following, as well as why we're following them, to answer some of the research questions that we're looking at. And then Pablo and I will talk a little bit about how we're hoping to partner with insurance carriers and payers around research, and how do we make sure that we are not only providing dynamic and responsive clinical care, but also being good stewards of our resources. So if we move to the next slide. We know that data is really important in terms of understanding not only what our patients need, but also what we need as an organization and as a field. So we know addiction is complex. Lanty talked about the many people who have co-occurring disorders, and with my background as a clinician, and Pablo also has background as a clinician, we know that more often than not, in our experience, if an individual is struggling with addiction, they are often struggling with a co-occurring condition of some sort, whether that's another mental health diagnosis or a chronic disease or a myriad of other conditions that can impact health and recovery. So in order to evaluate how we're looking at things, we really need to be thinking about standardized measures. And Lanty had some great measures there with the PHQ-9, the GAD-7, and some of these other standardized measures that we really need to be thinking about using not only internally as an organization, but across organizations as well, so that we can really look at as a field, what is the lay of the land? How are we doing? What are we doing? How do we set measures and metrics to make sure that we're all providing good clinical care to our patients? And to do that, we also really need rigorous methods. So we need to make sure that when we're collecting data, we have in mind what are the appropriate survey methods and research methods that are required to make sure that we have data integrity and that we're analyzing data in appropriate ways and consistent ways. And we also need to have, sorry if we can go back. Thank you. We also need to be informed by theory. So there's a really broad research literature on substance use, on motivations, on risk factors, on co-occurring disorders. And so we really need to be able to draw on that research of the body of research that exists to inform what we do, and also take what we do to inform that body of theory and research as well. And that is really so that we as a field and as an organization can understand what works and what does not. So some of the things that our leadership is really focused on is really around for whom does virtual work? And when does it not work? Is it different by diagnosis? Is it different by clinician? And so we're really exploring these questions around these variables, and so that we can better understand the care that we're providing and how we can be more responsive and really including not only the patient who is struggling with addiction, but also family members and children who are struggling with addiction too, and how those programs work virtually versus in person as well. So we are. Go ahead, Pablo.
Yeah, Quinn, I wanted to add to that as well. And I think that part of what you're speaking to is that the Butler Center for Research has been around for many years and an integral part of the Hazel Dominic Ford Foundation. And so when we look at this and we look at what to study, who we're studying, and then what to do with those outcomes, we're also really, we're pushing the community, but we continue to push ourselves as well in recognizing, one, that things change and that we can always improve. And how can we get a better outcome? And so part of this really is also refining our own work and our own approach. And I think what's important for us is that we started virtual before COVID. So we had that window of opportunity. We started it over a year ago, seeing that probably virtual would be needed, and that we began to formulate, both anecdotally as well as story-wise, as we watched our pilot, what did we need to look at? Because we began to discover things as we were doing them, as opposed to hypothetically trying to figure it out. And so I think that's where it's exciting to have you on board, so that we can really look at how do we now study what we started, and what were some of the experiences, and how do we even fashion those questions, because we started virtual over a year ago. So that's been really helpful as well. That's what I wanted to add to that point.
Thank you, Pablo. Yeah, so I mean, I think you probably hear the excitement in my voice about the research. I love research. I love talking about research.
Yeah, yeah.
But yeah, I mean, one of the really exciting things for me when I was coming to Hazelden Betty Ford was that they had already started this. So I have a background in mobile health and in virtual services, and I was coming into an organization that was already thinking about how do we leverage technology in the best way, best and most effective way possible to serve our patients. And so when the pandemic hit, even though it was a crisis and there are so many things that we struggle with, you know, as an organization and as a field, Hazelden Betty Ford was in this beautiful position where we had already started this process, and I was really able to come in and think about then how do we take this, and we have this unique moment in time where we can really learn a lot about how we provide services and move forward with that. So yes, thank you for that, Pablo. And that is really why we're doing this, so that we have the data that allows us to be really dynamic in our responses. Lanty talked about continual improvement, and that is what we have really focused on at Hazelden Betty Ford too. So in thinking about our patients and their needs and their families' needs, how do we respond as an organization to make sure that in addition to all of the challenges that we face with this pandemic, we are also continuing to address substance use and addiction and recovery in the most effective way possible. So if we can move on to the next slide. So our research questions, so I was tasked with really focusing on these questions around virtual services. And we focused really on our intensive outpatient program, but we've flipped many of our services virtually. So one of our questions is, does virtual provide comparable outcomes to in-person treatment? Now, the research shows us that for one-on-one treatment, that often mental health treatment that is in person can also be done effectively virtually or over the phone. But we have less information about groups. We have less information about intensive outpatient, about substance use treatment in particular. So those are some questions that we will be looking at. We're also going to be looking at which patients benefit most from virtual services. So we've seen anecdotally that there are some patients, depending on their clinical background, depending on their diagnoses, that actually do better in virtual services than in person. And we have other patients, again, depending on their clinical background, who actually may do better in person. So how do we distinguish that so that we can create the most effective hybrid program? What does that hybrid program look like? What components and in what ways? A third question that we're looking at is, how do patients who transition from in-person to virtual do during this public health crisis? So for those who, our patients were essentially forced into virtual because of the circumstances, how do they do compared to patients who may have been able to do in-person for all of their treatment? Or who did virtual for all of their treatment, or who would have chosen to do virtual. And then finally, how do patients fare with the transition from virtual back to in-person? So we'll really be looking at motivations for staying virtual or transitioning to in-person treatment. Why do some people choose one or the other? Why do some clinicians choose one or the other? Do we have clinicians that prefer to stay in virtual, or that prefer to go back to in-person and never touch virtual again with a 10-foot pole? We don't know these questions. And so asking some of these questions and following through with some of these surveys and measures is what will really answer some of these questions, so that we can make sure that we have the most effective treatments possible, both for clinicians as providers and for our patients. So on the next slide, I can describe how we're answering these research questions. And so we have 4 different groups of consumers that we're following. The first that is listed is actually our comparison group. And so these are the people who were in person for all of their treatment and were discharged within 3 months prior to our flip to virtual services. So this is the most proximal historical comparison group that we have that can really give us information about whether or not there are differences between sort of the brick and mortar services that we offered and the virtual transition. We then have a group that, the group that sort of stepped into virtual following the virtual transition. So these are individuals who started in virtual and finished in virtual IOP as well. So their whole IOP experience was virtual. And then we have our two sort of transition groups. So the people who started in person and then transitioned to virtual, and how those individuals fare. And then finally, the individuals who started in virtual and are transitioning to in-person. And so this will really give us a good sense of the nuance behind virtual services and when we might want to use them and when it would be best to do in person, or maybe even when virtual may be contraindicated. So if we move on to the next slide there. So we started collecting our data on May 1st, and we have now several hundred patients that we are following, and we're following not only at baseline, but we'll be following them for 12 months following discharge. So it's not just going to be sort of, how were our services then and were you better immediately after? Most of the research shows that immediately after, patients tend to do better because they've just come out of treatment. But how are they doing a year out from now? How are they doing 6 months out from now? So we'll be collecting data at 1, 3, 6, 9, and 12 months. We'll have some really good nuanced longitudinal data that will be able to speak to how people did through the public health crisis, how people did with the transition to virtual, and how people are doing following return back to in-person treatment. And so we'll be really focused on these sorts of evaluations and assessments, both at the patient level, the site level, and the clinician level, so that we really understand what works best for providing treatment for our patients.
And Quinn, I just wanted to add to that, if you could just go back quickly, just to say that also what happened was during this time, as we worked with payers, we discovered their interest in it as well, and moved forward with a number of payers, and now with all payers considering the COVID crisis. We had to look at what data and or articles were available, and most were on the one-to-one therapy. And as Quinn mentioned, and I just wanted to highlight, by doing this and what we're collecting now will really help revolutionize and understand better what virtual groups such as virtual IOP and the impact of that. But also even our move towards making our family groups virtual. Our family groups in person at the Hazelden Betty Ford Foundation were 3 days long. Now we converted it to a 1-day virtual. So this is going to really help us understand too, not only working with the patient and the clinician in that interaction, but then also understanding what does it mean to have a virtual program, as well as change it in order to match what we think will probably be the best amount of time for a family member being on a video. So that will really allow us to understand that. At the same time that we began to do all of this, our payer partners then said to us, what has been your experience, or what are you doing, or what are you measuring? So that has allowed us as a team, both my team and Quinn's team, to interact with the payers to say, what are your needs? We're not sure if we can measure them all, but let's open up the dialogue in the sense of how can we partner to really, in the end, I think what we all want are better outcomes. And in a time like this, we really want to make sure, as we see people are struggling, both we see relapse rates that have increased. Some studies have shown that people, over 50% of people while they're working are drinking. People are openly admitting they're struggling around mental health issues. So how can we really understand where virtual could play in a crisis like this as well? So I just wanted to add that part, and I wanted to thank you, Quinn, for all the work you've been doing.
Yeah, thank you, Pablo.
Well, this is Deb. I can't wait to hear what the research actually shows. It's very exciting. I can hear the passion in your voice and Lanty and Pablo, really just wanting to understand the data and what it will tell us.
Yes,
Pablo, is there
hopefully we'll
anything
have
else?
Oh, sorry. I was just
Go
going to
ahead.
say, hopefully we'll have some preliminary findings in the coming months and be able to share them with the field so that others will be able to benefit from the knowledge we're finding as well.
That's great. I mean, there's a podcast in your future. Pablo, anything more you want to say about the staff?
No, I think what it is really involving and looking with, there's such little research, and folks know that we are evidence-based, and we use our research to not only publish it, but also, for our own clinicians and clinical leaders. And then we study what we're doing after that's, been published, and we look at, publishing again, new findings later on. So I think we've had payers saying to us, so what are you discovering? How are you looking? So I think this is going to also hopefully help us be a good partner in working with payers to say, not only is it needed, but this is the population of patients that it works best with. This is what we find with clinicians, because we know that you do help providers and do help educate and advocate for good clinical practices. And then also the family is a huge important component to payers to be able to really make sure, as well as us here at Hazelden Betty Ford and folks like Lakeview, who really understand the need to work with families. So I think what I'm really excited by is not only the studying on the virtual IOP, but also virtual family and what that impact will be in supporting people, because many family really can't or don't quite understand what it means to come to treatment. And so this virtual program really might help them take further steps and also be accessible. And I think that's the exciting piece too, is that there are a lot of clinical deserts out there where there is no Hazelden Betty Ford or Lakeview. And so people don't know how far, or basically don't know where to go or don't have an option. And now this really opens up that realm. So now we'll have the studying. And I guess the last part is, how do we make sure people know about it and know that it works? And how do we tell the story? And so that I'll pass on to you, Deb, and to our payer guests.
Great. So I think in the interest of time, I do want to turn it over to the payers and their experience with telehealth during this era and what their plans are going forward. So I think our next speaker is Deb Nussbaum. Deb, are you there?
I am on. Can you hear me?
We can. Thank you.
Great. Hi.
So I think, yeah, the next slide, Stephanie, and Deb will be on point.
Great. Thank you. So I just wanted to point out that while employees might be feeling, fragile and concerned and anxious, they're looking to their employers for the support and guidance. And in turn, the employers look to United Healthcare Optum as their behavioral health vendor for how we're going to solve for all of the new levels of uncertainty that COVID bring up. We did a very quick survey, and you could see that at the top of the screen on employees' feelings. This survey was done actually the last week of March. We had to pivot very quickly to get on board with our reaction to COVID and what our response was going to be. So we have always tracked, and you could move on to the next slide. We have always tracked our digital activity and what we've been doing in the digital space through our website, through online virtual appointment scheduling, through members registering for virtual appointments, for providers who want to do virtual services. And you'll see that I just wanted to provide you this data because I thought it was really interesting data. If you look in the bottom right-hand corner, we had a 2,326.8% increase in virtual visits claims. That's amazing. You'll also see that our virtual visit referrals, our utilization for our wellness app, Sanvello, went up 125%. So the baseline period that you're looking at is from January to March versus March to May. So there was this huge spike. And we were happy to see it because we've had virtual services in play for about 3 years now, since 2017. And we've basically had a flatline trend. If you go to the next slide, you'll see what I mean. Okay, so the top, under claimants by service date, that actual red line indicates all of 2019. So that's my flatline data. That data was telling us that there was really no opportunity in the virtual space. It wasn't being adopted by our members. We've had a good virtual network. Providers were opting in to do virtual services, but the utilization was, like what I said, flatline. Then COVID and the entire crisis, and you'll see the green line gives us that that trajectory up from March to April. There was a straight line right to the top, and that's where we had to say, we need to mobilize. We need more providers in the network. We need to remove any barriers to providers doing virtual services. Prior to COVID, we didn't even have the ability to reimburse facility-based services, any services billed with a HCPCS or a rev code in the virtual space. Basically, we were only reimbursing CPT codes, individual therapy, group therapy, family therapy, med management. We had to pivot to say, okay, now we need to open up our virtual services to intensive outpatient services and even medication-assisted treatment services, because our members needed to remain in care. Our employers were asking us, what are we doing to make sure that people have continuity, because they don't want to see members regressing to their disease. So this was all something that was put into place very, very quickly. If you scroll down a little bit to the bottom of the screen, you'll see some of the primary drivers for virtual services. It's always been high in depression and anxiety, and our highest utilization has been in the outpatient, medication management, and professional services, psychiatric services. So very much a change in our mindset from pre-COVID to where we are now. And you can move ahead to the next slide. Oh, that's the other half of the diagnostic categories I was just telling you about, the top utilization. So since March, we have added over 1,000% of our virtual services. When we say added, we mean that we maintain a virtual attestation. Providers doing virtual services need to attest that they are using secure technology, HIPAA compliant, any of the technology that is approved and secure. So you'll see that there was a huge increase in providers wanting to do telemental health services after March. Our baseline was 78, and then we started to receive 903 a week. So quite an increase. And you can move to the next slide. So right now, in our data, we have a virtual network of over 12,000 virtual providers. We have other digital tools like our Cinvello app, which is a wellness app that's available to anybody. You could go to the App Store, download Cinvello, and you have access to a free app. Optum United Healthcare actually owns Cinvello, so it's a wellness tool, self-guided, CBT, very, very nice app. And we've had it for months. We've actually had it since last year with very little utilization. Now we're seeing that utilization. And then our new virtual solutions going forward. We're allowing virtual MAT utilization. It's not that it's allowable from us, the insurance, but the regulations related to prescribing MAT virtually have essentially been relaxed. and also providing the more complex IOP and PHP therapy virtually. That's also we're covering that right now. We're actually, on the right side of the screen, it says through July 24th. That is going to be expanded to September 30th. We know that we will be reimbursing those services. And what we're doing is, while right now it is considered to be a temporary accommodation for this situation, we're going into the evaluation phase of whether we want to keep this as a virtual option. We have a lot of questions. We have no experience with utilization. I showed you our virtual utilization dashboard from last year. We actually had no virtual group utilization, very little, prior to the COVID. So we really don't know what to expect. From our vantage point, our customers look to us to say, are you going to continue to cover these services? Are these services providing value to our members? So we're going to be entering into an evaluation phase. We're going to be interviewing members. We're going to be looking at the treatment outcomes. We don't want to do that prematurely, so we're going to give it some time. And we also want to make sure that there's really good information from the providers, and I appreciate Lanty, and I appreciate what Pablo and Quen said about research. It's really important that we understand who should be receiving virtual services versus who should be seen in person. What embedded measurement are in these virtual IOP and PHP programs to make sure that our members are getting value from the care on an ongoing basis? And then, of course, Lanty, I think, said this earlier, and I agree with her. How do we solve for the necessary screenings that have to occur when someone is in an intensive level of care? We have labs, we have breathalyzers, we have medical services. It's really easy when you have the member in front of you versus, virtually people can kind of, be on but check out. So we want to make sure that we're doing a really good evaluation of whether we want to continue with these services. And so that's undecided right now. We will certainly let you guys know. But for right now, they are covered. They're covered through September 30th. And we're really happy to see an increase or an adoption of our virtual platforms. I think that the new normal after COVID, we will probably continue to see at least some increased baseline. So that's everything that I wanted to share with you. I'm going to turn it over to my colleague at Cigna.
I have to unmute my phone to get going here. Hi, everyone. I just want to first thank Open Minds for continually gathering us together on these important topics that are affecting our industry and provide that thought leadership we all appreciate so much. They're always so gracious to us to thank us, so I wanted to take the moment to thank them as well for all that they do for our industry. So our story here at Cigna isn't too terribly different than often than what we have experienced, and we have very shared experiences. So I thought I would walk you through how our story unfolded since mid-March, and not just from a facility standpoint, but also want to sprinkle in some of the outpatient information too, because they do all affect one another. So as the country started social distancing and self-isolating, we, just like often, were incredibly concerned to continue to be hyper-focused on the mental well-being of our employees, of our clients who are employers, of our customers who are those employees at our clients, and our provider community as well, and then the community as a whole. And I see, I kind of observed when this all started escalating, it was really great to see the entire healthcare community come together to address specific community needs. In our world, that meant payers teaming up with other payers and coming out together with how things are going to be reimbursed in a COVID world, whether it was from a virtual standpoint or just for actual treatment. So as I walk through our timeline, I think as everyone else, pinpointed pre and post COVID when it comes to virtual services, when CMS had their Monday press conference that relaxed so many of the guidelines around telehealth and the delivery of telehealth services. So from that time that press conference occurred, I think it was on the 16th, March 16th, within 24 hours, we had over 4,000 providers on their own go to our provider website and sign an attestation to deliver care virtually before we were even able to issue any guidance and say, here's how you bill, here's what you can do. We've been reimbursing for virtual care since 2017, so the lift for behavioral was pretty easy for us. We just needed to get the information out in front of providers to say, here's how you bill. And for the first time ever, we also were able to say, here's a free platform to use that's HIPAA compliant, because there's always those associated questions with which platform should we use. Our outpatient network, part of our guidance was, you don't have to sign the attestation right now, just figure out how to do it so people don't lack receiving services. But the outpatient network of providers, we're up to 30,000 providers now who are offering their services virtually. We know it's much greater than that, but we'll worry about getting the attestations letters okay for now. We were also able to quickly get certain digital providers contracted into the network, like Talkspace. And I bring that up because as you think of transition plans and discharge planning, for those of you out there from facilities, and if you're delivering care in a virtual world and you want that discharge plan to seem seamless, for Cigna customers, there's Talkspace as an option, there's ND Live as an option, and a network of 30,000 providers who are offering their services virtually, so it can be an easy transition for the patient. We also doubled the amount of EAP visits that we offered to our clients. So if they had purchased, for example, a 5-session model, we increased that to 10-session model for COVID-related care. And we also accelerated credentialing, the credentialing process in all of the hotspots across the country, just to ensure services were not being interrupted. Then for the facilities, it was about within 72 hours of CMS's announcement that we started having an influx of facilities saying, what do? We pay for this? How do we get started? And we had already actually been reimbursing for virtual IOP for about a year. And then, of course, we're allowing for PHP during this COVID time to be reimbursed for telehealth. But there were a lot of nimble facilities and hospitals that figured out how to do it really quickly, which we thought was great. And we hope to see they'll continue to offer virtual IOPs. For example, it's really hard for some folks to get to an IOP 3 days a week or 3 nights a week. And I'm going to use Pablo's term because I think it's such a great term. There's the clinical deserts out there where someone may have traveled to a facility for care, but when they go back home, 200 miles away, there's hardly any opportunity there to receive care. So we think the more virtual things can be done when appropriate, it really helps in those rural areas as well. It also helps in metro areas, we find with our data, because of the traffic, basically. And as we've learned today, treatment adherence has increased with virtual care, which is really exciting to see. And we've been working with Hazelton actually for the past year, as Pablo mentioned when they started, on how does this look from a clinical appropriateness standpoint. And we've also had been working with a large multi-state eating disorder facility system that, again, they had people traveling to their inpatient and residential facility for care, but needed to go back home to another state. And so to continue that relationship and continue the progress that's been made, they started offering virtual IOPs as well, and so we've been reimbursing for that. But when we look at our outpatient data, so outpatient meaning not IOP, PHP, but individual therapy and psychiatry, we had the same experience that Optum did, where we had 1.6% of all claimants receiving care virtually, and once the flip was switched, it went up to 53 or almost 54% of the number of claimants receiving care virtually, and that was a 3,200% increase. And for the total number of visits, we had over 4,600% increase in that. So, and we know it's even greater than that. It's just what we can tell with claims when people actually used the modifier when they submitted their claims. The other interesting piece from an outpatient perspective is that of those individuals that had the giant increase of the number of individuals who are receiving care, 97% of those people who received care after the isolation started and the lockdown started had never had a behavioral claim before. So as Deb was saying earlier, that, you know, there's a lot of anxiety around the world we're living in right now, and people are needing services. So when we look at hospital and facility utilization, it was kind of interesting. Those first 2 weeks, we saw a decrease in admissions overall, and then slowly we started to see that go back up to normal standards on the coast, especially. And so then there's some unique nuances. So like in the state of Pennsylvania, they shut down all the liquor stores. So they had this surge of detox admissions across the entire state. They could hardly handle the volume. So that was interesting to watch as well. But from our specific utilization, you can see in that middle box there that for PHP, we went from 0 to 12% of claimants having a telehealth claim, and a 10% in overall visits. But we had, you know, again, a decrease in overall utilization for PHP and IOP. And we had the same experience with IOP, where we went from, I think it was 0.4 to 17% people having a claim for telehealth IOP, and then a 40,000% increase for visits. So it's, again, the facilities, I feel like, were really nimble and quick to figure out how to do this, and we greatly appreciate that from them. So what we're looking at for the future, what we want to see is, from an IOP standpoint, if it's clinically sound and clinically appropriate, I love to hear that facilities are looking at what does that look like, because we really rely on them for the clinical efficacy of their program. But we want to see it continue. We'll continue to reimburse. That's not going to stop for us. We'll also begin to start contracting for virtual only IOP. So there's quite a few substance use programs coming up where they have a virtual IOP and perhaps just peer support associated with that. If they can produce the same type of outcomes, we're happy to reimburse them for those services. And we want to ensure that our customers can locate them appropriately. And from a measurement standpoint, I think what we'll probably do, at least for this first year, is look at telehealth outcomes versus non-telehealth outcomes for facility-based services, as well as for outpatient. Look at them differently, but really just do your bread and butter, what we always look at, and then do some customer satisfaction around that too, because I've heard from some people, as we've talked about already, that they're not comfortable with telehealth because they don't want to see themselves on camera, for example. And if they were to be upset and crying, they don't want to see themselves cry on camera, so they hold it back. So it's kind of some interesting elements of who's using it and how they're using it and why they want to use it. So from a PHP standpoint, I think the jury's still out. That's, you know, people are really fragile in PHP. It's such a fine line between PHP and inpatient that I think it will be a lot harder to systematically create a virtual PHP. But again, we would be open to reviewing someone's clinical aptitude around it, and it may depend, I think, on the diagnosis as well. For outpatients, though, we'll just continue to grow, and if someone wants to be seen virtually, we'll continue to reimburse, and we'll continue to grow our network around that. So I think overall, a big picture, because of this new world we live in, I don't think there's any turning back. And our medical partners feel the same way in many ways. So I think the more that a provider can do to figure this piece out and what makes sense for them and their practice and their operation, the better they'll be in the long run. And so that concludes my part.
Thank you so much, Erin and Deb and all of the panelists. We only have a little bit of time for questions, and we have had some through the chat. I'll start with Erin. I see the virtual only IOP, so you would be looking to, it sounds like, credentialing contract with a IOP provider that doesn't have bricks and mortar. And if I'm understanding you correctly, have you are you expecting any type of different criteria than typically required for IOP?
Yeah, we're working out the credentialing criteria around that, but the Joint Commission is actually accrediting these virtual IOP programs, and so we'll probably follow their guidelines more than anyone's. And then they'll, each state has its own licensing requirements around that, and so we'll look to how the states are handling it too.
Yeah, that's the tricky part. I know each state has their different rules as well. Well, thank you.
Right.
And then we had a question for Quinn, actually, on the slide 19, when you were talking about following consumers and studying these different cohorts. And I think it's really exciting because, you have individuals who entered treatment during COVID, right, and know nothing but a virtual program, right? They started in virtual and maybe finished their program in virtual. So one of the questions we saw in the chat was, what are some of the measurements you're looking at as you look at these different cohorts?
Yes, so we are looking at some generally consistent measures similar to what Lanty's organization is looking at in terms of the PHQ, the GAD-7. We're also taking measures of overall feelings of well-being and also economic strain, parenting stressors, and we have some measures in there around working alliance with clinicians as well. So those are questions that we'll be asking the people who are virtual and transitioning back and forth.
Okay, great. Yeah, so a lot of consumer reported outcomes, it sounds like, therapeutic alliance, et cetera. Deb, I wanted, no, go ahead, Quinn.
Oh, sorry, I was just going to say, in addition to, sort of what we already have around readmission rates, length of stay, and that kind of, those standard measures that most places, I think, collect, and the clinician level measures as well.
And length of stay is an interesting one because I have heard from other IOP providers that they've seen longer engagement, maybe not substantive, but maybe 2 or 3 more sessions, or another extra week or 2 of IOP services during the virtual period. Have you had a similar experience at Hazleton?
I haven't heard that. Pablo, have you heard that? I have not pulled the data yet. We're kind of waiting to see where some of that data is. But Pablo, have you heard anything about increased numbers? I know our engagement is up like many other places.
No, yeah, so I think like many, we see engagement up. We also saw absenteeism drop. So what we saw was folks successfully completing the program in the time that they were, that we felt they were necessary to be in the program, and as well as to move them on to another level of self-care. So no, Deb, we hadn't seen that. I mean, we also involve folks in various tools that are online for recovery management that the patient can use. So they become more encouraged as treatment goes on, so that we're driving them less clinically and really moving them to a place of self-management. And so I think we haven't really seen the increase in time, but really going after a lot of resources online and some of the things that we offer. So for example, like we offer the Daily Pledge, which is open to anybody actually. And it's, for lack of a better way of describing it, it's a Facebook for people in sobriety with online meetings and tools to interact with folks. So I think if anything, what we've seen is a jump in folks utilizing both our clinical levels of care that are virtual, but also the things that are just available to the community, like the Daily Pledge, and our family online assessments. So that's what we're increasing.
Yeah, so I
Great.
think we've really had a lot of expanded online resources with our Recovery Go, and so people have been able to access as needed in addition to connecting with peers online, which I think has really helped individuals.
Yeah, we saw a huge spike. But what was great was, again, we had the resources already in existence. So the base of some of the folks that ran online meetings and the peer supports through our Recovery Go, which is our umbrella for all our virtual services, those supports saw a big jump. But what was great was there was a foundation so that folks were able to go and still go to a meeting that was an online meeting, but by somebody that had led an online meeting for quite some time. So I think that's where we've just seen people engaging, and the feedback we have heard, Quinn, the oral feedback from counselors and what they report patients saying is really this is the only time where they either get to focus on themselves with other people about their addiction, because it's the only time they can close the door and have a separation from family or friends or partner.
Mm-hmm.
Whether it's a good relationship or it's a relationship that still might need some work, it's their time to be alone as well as just feel connected for themselves to a group. So in some ways, you can live with many other people during this lockdown, but be mentally isolated. And so what we have found is people are reporting that they feel less isolated by having this. And we've been questioning, even with partial hospitalization programs, and we know that we're not sure where that's going to go as much as the virtual IOP, but people sit there and do it because it is their treatment and they're excited to be engaged in it. Because it's like the only outside time they have, even though it's in home and on video.
It really opens up access in a whole new way. I know programs that have now gone from 9 to 5 weekdays to weekends, evenings, and just the whole flexibility. I want to make sure we squeeze in a quick question for Lanty and Deb Nussbaum. Lanty, I was really impressed with your ability to obtain testing materials, even I'd say early on during the pandemic. And any I don't know, what were the tips and tricks, and how did you manage that, getting access to those?
Yeah, no, we were very grateful that we had long-standing partnerships with Mayo Clinic. They're local here, and they have a lab that they've basically partnered with a lot of our local agencies, police department, fire department, other smaller hospitals to provide the testing. So we were very fortunate with that partnership. And then with our lab that has a heavy presence here in Florida, BioReference, they actually are processing a majority of the South Florida COVID tests, and we were already in a really good partnership with them. So we were able to, at the beginning, just go ahead and start testing. So just those partnerships, building them early on, kind of like what Pablo's saying, with having that foundation already set, it really makes it so much easier to be able to pivot when you need it. And it's already a platform set. So that's really where we were very fortunate. And again, we continue to have really good results with them.
Deb, this is Meena. If I can jump in with a question for Lanty. Lanty, you talked about being fortunate that medical care, that primary care was embedded in your system, and that helped you really take care of people with the co-occurring disorders.
Yeah.
Does Lakeview actually employ people, your own primary care clinical professionals, or is that a partnership as well?
No, we actually have a full-time internist, board certified internist and addiction medicine provider on staff. She's our medical director, and we also have a board certified mid-levels, 2 of them who are in primary care. And so we already have them. They're full-time. They work on site every day. And then we also have board certified psychiatrists. And then one of our psychiatrists is actually a family practice doc as well. So he has dual training. So we're really, all of these people are full-time for us.
Great, thank you.
Mm-hmm.
I know we're about out of time. Deb Nussbaum, I just wanted to check quickly. I think you said you're going to continue, you're extending that July 24th date to September 30th. Did I hear you correctly in terms of allowing for virtual services?
Yes, virtual IOP and PHP will be reimbursed through September 30th.
Gotcha. Okay, just that was a change. Well, you know, I know many of our panelists probably have other meetings to attend to, but I really hope that we can bring this group together for maybe a podcast in a few months so we can hear the rest of the story, to hear what the research tells us, to hear if, you know, the measures change or adjust as we reopen, if you will, post-COVID. But again, thanks very much for our speakers and all that you imparted upon us today. It's just been extraordinarily helpful. So thank you.
Thank you, Deb.
Thanks.
Thank you. Thank you, Deb, and thank you, Open Minds.
Thanks, everyone.
Hey, guys.